Dr. Christian Cuddy and Dr. Lapellis are up in Simi Valley. They operate within a large family practice and again have physician's assistants, nurse practitioners, as well as themselves. They act in more of a consultant role for the more advanced, difficult pediatric patients. And we had some difficulties getting started, but you really picked a key in that you were able to engage the director of your clinic, who's an internist. So we have a manual of how they went about implementing this available, and if you could just talk a little bit about how that came about, and who was at that meeting?
Well, Dr. Lapellis, who wanted to be here but is covering the hospital right now, Dr. Lapellis and I have thought about basically implementing AAP recommendations and making sure that all the kids coming through our clinic were screened, just because especially when you have a variety of providers, you're just not sure how uniform developmental surveillance is going to be. So screening kind of gives you some uniformity across the board, and you know that certain, at least minimal standards are being met. So that's why we thought it would be important, knowing that we do have such a busy clinic and MAs who already had a lot of responsibilities, of course, regarding distributing books and fluoride varnish and stuff. So we were a little concerned that it might be resisted at the beginning. So what we first did was just bring it up with the providers. Some of the providers initially felt that, well, we're already doing surveillance. I don't really come across kids who have a problem, so this is just extra work. And so initially it wasn't, I wouldn't say it was a problem per se, but it just required a little more discussion to show them, hey, these tools really aren't that difficult to do. It gives you a sense of security that we're not missing anything. And I think once we kind of discuss, like, you know what, this is coming, this is the standard of care, and it's not that hard, then I think everybody amongst the providers fell in line pretty easily. At the time, our director was Dr. Reeves, so he was pretty amenable to it, and then sort of the rest followed from there. So at that point, we were more concerned about getting the staff excited about it, because I just feel that when people are told what to do and not really explained why, they're more likely to be more resistant to things. So we decided we were going to set up a big 2-hour session workshop, which involved lunch, just to be a little extra incentive for people to be excited. And the employees were all, paid during that time. And I was surprised at the response. People were actually, at that meeting, were very responsive to it. So what we did in the first, probably of the 2 hours, in the first probably 30 to 45 minutes was to give background. So when you look at a copy of this guidebook that Dr. Lapellis and I created, the first half of it really is background that you probably will already have gotten out of today's conference. So there's not a lot of new information for you all, but that was what we used as a intro to our staff, in terms of, this is the background on development, this is why we do these things, this is why it's recommended. And then for the next at least hour, maybe more, was really brainstorming and really trying to make sure that the staff felt involved, included, asking them, is this feasible? If not, why not? How can we change it? So we had decided pretty much to leave things really open, to say, well, we're going to choose the most simple tool that we can at the outset, and then if there is additional screening that needs to be done, the providers can kind of handle it from there. But as far as medical assistance, it's simply the PEDS developmental screening, and then that MCHAT for autism at two of the well-child visits. We did change the AAP, as was mentioned before, recommends the screening, what was it, 9 months, 18 months, and 30 months. So of course there's no 30-month visit for us routinely, so we changed it, the 30-month, to just be the 24-month visit. And then the 18-month visit, we just split the tools a little bit. So essentially what we are doing is, at 9 months we're doing a PEDS, just basic development. At 15 months we're doing another PEDS. At 18 months we are doing an MCHAT. And at 24 months we're doing both the MCHAT and the PEDS. So the 24-month visit becomes a little bit more labor intensive for the MAs, but we just felt that in terms of frequency of visits, by the time they're since they're only coming once a year, it's not as much of a burden. So that's how we decided to do it. So far it seems to be working well. I haven't gotten any complaints from anybody. I've asked around as far as, you know, workload and stuff. People seem to be okay with it. I haven't done audits to see if people are actually implementing it, but I do know that they keep asking us for forms, so that's a good sign that things are moving along.
You know, when I mentioned that we focus on change and tests of change, it's just that when we're at Mandalay Bay, just know that in any clinic system, or in my clinic is different from Dr. Babra's clinic, is different from Dr. Krishnakutty's clinic, and so what might work in my practice may not work in somebody else's practice, and that's why we encourage you really to test out things on a small scale and for a short period of time before you actually implement them into the clinic system. One of the examples of what we did with the developmental screening project is that we first started by choosing or deciding which form we were going to use, either the PEDS or the ASQ. And that was done with only one pediatrician who kind of spearheaded that. They were the physician champion. And so based on the results of what she was able to accomplish, we chose the PEDS developmental screening test or tool over the ASQ. We still do have the ASQ that's available for those children who we're worried about when we do a PEDS test and we want them to come back for an additional testing. We'll do the ASQ, or it's there and available for any provider to use if they so choose. Then we sort of started into trying to define, well, how best are we going to make this work within our clinic? Because again, I'm really a strong advocate of not one person shouldering the burden of having to do a specific task. And really when we're talking about taking care of a patient, it's the patient care team, not just the provider, not just the back office, not just the front office, and not just the administration. And so collectively, what we initially started was a test to see who's going to put that form in the chart so that the provider has access to it, or so that the parent fills it out and then the provider's able to fill it out. We started by testing out with the medical assistant putting that chart or that form into the chart at the time that they were actually working the patient up. Found about 50-50. So about 50% of those patients would actually get the form put into the chart and the other 50% didn't. And so collectively we reconvened, and the next test that we're going to be doing is a different kind of idea, which really will involve the whole team. We do morning huddles, and I'm not sure, raise of hands if anybody does morning huddles in their clinic. I would strongly encourage it. In our morning huddles, we open our doors at 8 o'clock, but our first patient for pediatrics isn't seen until 8:20. And so from a period of 8 to 8:20, the provider, if they so choose, and we encourage that, the back office participant and the front office meets in the front office, stands by all the charts, and makes sure that everything for that patient visit is in the chart. And so during the point of the team huddle, we'll be putting these forms into the chart, making sure that they are already there by the time the patient's called back.
Thank you.